So next we have our telemedicine panel. So if you can come up here if you're a panelist.
Good afternoon. I'm Glenn Pearson. I am principal of a company called Pearson Health Tech Insights, and I worked at Georgia Hospital Association for more than 19 years as executive VP, and now I'm helping companies. I'm sort of a translator between executives and technology folks to help see how technology can be implemented to help make some positive changes in how care is delivered. We've thrown a lot of stuff at you today. It's been a great program so far, and I'd say it's a mix of good news and bad news. I mean, there's been a lot of troubling statistics about opioid addiction and the economic condition of rural hospitals and all that. This last session was very encouraging to have some bright spots about how some changes can be made, and I think the session we have now is going to be a continuation of that. We try to talk you off the cliff, with all the bad news here. There is a lot of good stuff happening, and technology can help to make a difference in that. So we've assembled a really strong panel of people who can speak specifically to telehealth and telemedicine. So I'm just going to mention them by name, and then they're going to introduce themselves. And I believe a couple of them have some slides that they want to show just about their company. So immediately to my left is Tanya Mack, who's the president of the Women's Telehealth. And then next to her is Julia Dreisen, from University of Pittsburgh Graduate School. And then down on the end is Steve McGraw, who is the president and CEO of Reach Health. Now, you notice in the program we had a fourth person, Erica Baker, was scheduled to come, and I got here a little late, but I understand she did come, but unfortunately got sick and had to leave. So she made an effort to be here, but so you'll have to settle for the four of us instead of five. So anyway, let me just start with Tanya. If you could just say a few words about your organization, and then we'll jump into the content.
Okay, so I'm happy to be here. Thanks to Bowling and Company. Tanya Mack, president of Women's Telehealth. We are actually on the service provider side, so we mostly provide high-risk obstetrics, infertility, and genetic counseling services by telemedicine. In the 7 southeast states we're licensed, so the Carolinas, Tennessee, Florida, Georgia, Alabama, and hopefully soon Mississippi. And we're privately held. We're 99% electronic. We use a variety of platforms. We're neutral in terms of hardware and software that we use. We've completed about 17,000 high-risk MFM visits in the last couple of years.
I'm Julia Dreesen. I'm from the University of Pittsburgh. I'm an economist, so you'll get a second one of us today. I'm interested in thinking about how the market can support value-added applications of telemedicine. I've primarily thought about this in the context of nursing homes and potentially avoidable hospitalization, so I'm very interested in sort of outcomes that are both clinically undesirable and economically adverse, and thinking about how health IT can fit there.
I'm Steve McGraw with Reach Health. We provide a technology-based platform for all kinds of settings as well as service lines. And the company's got a pretty interesting start in that it started off at Medical College of Georgia, now Augusta University. I assume Dr. Canto, you were there at the time? So Dr. Hess and the team were seeing stroke patients outside the treatment window for TPA. As most of you know, TPA is a high-risk, high-reward drug. So they realized that if they could see the patient, hear the patient, and also view the brain scans, they could make a remote decision on TPA. And the program was wildly successful. They spun it out of Medical College of Georgia, and then it became a private company backed by private equity folks called Reach Health. So today we do roughly 1,000 stroke consults a month across the country. Also do pulmonology, behavioral health, and pediatrics. So they all work, or you got the one that works?
Yeah, this one definitely works. Okay, so I think one of the biggest questions that always comes up on telemedicine and telehealth is, what do we mean by that? The definitions are all over the board. So I'm just going to ask each of you, and we'll start with Steve, what is your definition of telemedicine?
All right, so you're right. You ask 10 people, you get 10 different answers. The way we think about it is essentially more than just an AV platform. It's more than just seeing the patient. You also want to collect data about the patient. You will provide a toolkit for the doctor or the clinicians to make a more accurate, fast decision. So ideally, you start replicating the bedside experience in remote encounter. Also, it needs to kind of follow the patient, if you will. In other words, the patient may be in a high acuity setting, take stroke, but then they're discharged and there's rehab. So let the same system follow that patient through the recovery phase. So we think about it more than just a simple AV solution. And a lot of times I use the term that where the market is today is essentially like the AV solution, like the flip phone of cell phones. It's sort of yesterday's technology, and we've kind of moved well past that now. So, but there's like 10 different legitimate definitions to telemedicine. So.
Yeah, so in my work, I mostly think about the synchronous video aspect of telemedicine. But I will say, in terms of thinking about the role of policy, in terms of ameliorating the outcomes that I talked about, I think the definitional piece is a real challenge because it is so murky. And even now, if you were to define something that reflects the market opportunities today, the longevity of that is difficult to sort of capture in sort of today's legislation.
So I'm kind of with Steve. I think telehealth is a broader application of uses. We use it for long distance learning, clinician to clinician. A good example of that is a couple years ago we had some 12, I think, physicians, I think we just lost this, come from the Republic of Georgia over to train at our facility. They said, "Oh, Tanya, we use telehealth all the time." I said, "Well, what do you do with the patients?" "Oh, we don't use it with the patients. They use it to train other doctors." So we do the same. One of the challenges of rural Georgia, real honestly, is often not the technology, it's the people on the other end. So train the trainer is a piece of telehealth. I think also if you look to how the states define telehealth and telemedicine in terms of reimbursement, you will get a very broad, probably 50 different definitions on their legislation about telehealth. But I think of telemedicine involving clinician to patient, telehealth being much broader in terms of its scope.
And I'm actually going to suggest even a broader definition. I'm going to take liberty as the moderator. Since it's supposed to be 4 panelists, I'm going to be 3.5, so I'll say a little more than the moderator normally does. But the work I do, I'm dealing with technology in general, and I make a distinction between what I call, when I'm in a good mood, I call it classic technology, or when I'm not such a good mood, it's old school. It's EHRs, it's infrastructure, it's compliance with HIPAA and all that stuff. So that's old school. Then you have all the emerging disruptive mHealth, digital health, all that stuff. And then I divide that into 4 buckets. You have patient touching things. So you have diagnostics and therapeutic intervention, which literally touches a patient. Second bucket is personalized medicine, genomics, IBM Watson, personalized care, that type of thing. The third bucket is clinical communication, either patient to physician or among different clinicians. And then the fourth bucket is standard business functions, scheduling the OR, HR functions within the hospital. So, like you said, there are 50 different definitions in states. There are probably, as many different opinions as you get. So we're going to kind of go from more narrow to broader and back and forth a few times. So let me just ask you guys, which would you say are the most significant service lines or product lines or areas that telemedicine, telehealth, emerging health can have an impact on? So who wants to take that one? Steve?
All right. Here's how I think about it. It's basically thinking about continuum from, can it help save a life? Can it help prevent someone being disabled or less disabled? Can it help someone prevent a condition that might be coming on? Or can it help someone for convenience? Can it help a chronic disease? Can it help someone who's near the end of life and make their life more comfortable? So I think about it in terms of continuum. So like where Reed started out was in stroke. I mean, I literally have had doctors call me after they treated a patient, and one doctor told me, the quote was, "I've been in business 30 years. I've never seen a miracle like this in medicine since the day I started practicing." Because he was the first time he delivered TPA in a remote encounter. So that, and the person was aphasia, in other words, totally couldn't walk. 2 days later, they walked out of the hospital. So it's not just, this combination of the drug and the ability to deliver the drug, but then you have cases where the simple cases where someone is a pulmonologist and the family doesn't have to drive 60 miles up to Jackson, Mississippi. They can just see the pulmonologist in the local remote hospital, saving both doctor and family time. So not urgent, but highly convenient, right? So I kind of think about it in terms of a continuum is how I typically think about it.
All right, so not a clinician, not an informaticist, but for me, I think that the nice thing is that often the clinically sort of significant outcomes are also the financially significant ones at this point, right? And so that duality really can't be denied and is actually a really good thing. So yes, I think about it sort of starting from sort of the largest impacts, which usually has to do with mortality, and sliding backwards.
I tend to think of it as evolutionary as well on that continuum. I think traditionally, if you look at telemedicine's been around for over 30 years through the military and through the Medicare program and specifically, but it covered very limited, very few specialties. Now we're seeing it at CVS. We're seeing it in retail. We're seeing it in schools. So I think that it's just continuing to evolve into a wider geographical service area and evolve into a number of specialties. Not just, I think traditionally we saw behavioral health, ICU, strokes for 20, 30 years, but it's really expanding into many, many different areas today.
Yeah, and I think that's an excellent point because I think part of it is the improvement of the technology, the capability. And, we heard earlier today about broadband access and all that. So the infrastructure is getting better and the technology is improving. I mean, you mentioned flip phones before. How many of you have a flip phones? Let me see your flip phones. Okay, well, those are gone, right? Yeah, where's Bill? So, the technology has moved along. So we're able to take advantage of it in clinical situations that weren't possible before. So that raises a big question. I'm going to ask this one of Julia. You've studied, technology and telehealth nationwide. What would you say are some of the biggest barriers? Why is telemedicine, telehealth, emerging health, whatever you want to call it, not more prevalent in rural areas?
All right, sure. And so I'll probably ride this theme into the ground, but I think it's twofold, right? So I think the first challenge, which almost anyone would tell you at any level involved in telehealth, is reimbursement, not just in the short run, but also in the long run. So the idea, I think the thing that has happened, there's been momentum with telehealth policy, specifically telemedicine policy. So it's widely known that sort of Medicaid is one of the front runners in terms of creating room for telemedicine and reimbursement, but that basically means that you have 50 plus models running around, and then Medicare has been a little bit more cautious and reserved in getting into that game. And so I think that creates a very murky business signal in terms of adoption, because while those policies have arguably created demand, they haven't automatically created supply. So they've opened it up so that now you have residents in rural areas that can get telemedicine, but that hasn't necessarily, it hasn't been a sort of build it and they will come kind of thing. So you still have a supply issue by and large, right? This idea to adopt, and I think that business signal, or the lack of one, is part of the problem. I think the other thing that's going on here that isn't financial at all is that usually when we think about technology diffusion, we think about an S-curve where you have your initial sort of innovators and then there's this externality and it feeds off itself. But this isn't just sort of a new drug, which is the common example of that sort of S diffusion curve, because it's more than just sort of, well, okay, I'm not a clinician, so maybe I'm oversimplifying this, but it's not just sort of changing what you write on the prescription pad at the very end, right? There's this adoption, utilization, implementation, that whole thing, which is sort of outside of what many of our providers are trained to think about when it comes to thinking about technology and the workflow and everything that goes into that. So I think that that's sort of the main issue, is that this isn't something where creating demand, this isn't direct-to-consumer advertising, right, which works to some extent with pharmaceuticals in terms of spurring adoption. It's not going to work that well. We have seen it not work so well in telemedicine. To me, it feels more like what's been done, for better or worse, with meaningful use in EHRs, where there's been a much more concerted, handheld effort to help not only with the financing piece, but also with the how-to piece. And so I think those work well. The lack of attention to both of those together has sort of stymied telemedicine adoption.
I think I'm glad you pointed out the payment side, the reimbursement, because I am really confused about that myself. I keep hearing different things. So I would like one of you experts, if you can, to tell us what is the status of payment, particularly in Georgia, we had a Medicaid representative here. She's going to speak on that, so maybe, this might be a little softer an answer, but, inform us what payment is available for telemedicine, telehealth services in Georgia.
Well, as the one on the panel that depends on the payment, I'll start. Let's put it that way. Okay, so let's just look at it in terms of categories. So Medicare has covered telemedicine for years and years. We have made some slow progress. They pay for a lot of specialties, but there's some they don't. They have traditionally paid for recipients to receive care in small rural areas, which they've recently expanded the population requirements, even though it's available and needed in urban skilled nursing facilities as well as rural. So Medicare does pay, and they pay with limitations. And
So I was going to interrupt. Sorry. So the concept was probably the geographic proximity.
yes, yeah, which is kind of still applies, but also doesn't apply. So that's Medicare. Medicaid, we are very blessed in the state of Georgia that we have had Medicaid reimbursement in Georgia for maybe over 10 years or almost 10 years. Medicaid pays all four beginning in July. We have our fourth CMO. They will be paying. We have parity law. We're studying in law school. We really haven't talked about that in telemedicine, but parity law, even if there's a payer that pays, they don't have to. Okay, so in some states, the carriers may pay, but they won't. But in Georgia, Medicaid pays as if I'm there. So certainly in rural populations where it is heavily Medicaid population, we do get paid as same as if we're there. And why you're confused in part, Glenn, is because the payment is all over the board. And so let's talk about the commercial side. In states where we have parity law, here in Georgia, we do have parity law. The commercial carriers, Aetna, Humana, Cigna, United, they all pay as if we're there. So there is very good reimbursement. They're able to determine it's a telemedicine visit by using a GT modifier. So they can tell whether they're paying in person or telemedicine by adding a modifier to it. We are dealing a lot in my company with our contiguous states. Florida does not have parity law. Medicaid pays for a very few specialties, not others, not primary care, pays well for pediatrics, not for other types of specialties that are needed. So another good example, Blue Cross Blue Shield in Alabama, no parity law, pays only for 4 specialties. So we're trying to get it expanded. So I think the reason there is a lot of confusion is because some states have parity law that requires if I am giving the care and I tell you what to do, and I can do almost a virtual exam with Bluetooth technology and peripheral tools and otoscopes and light scopes, and you can sue me over the care I give, but you're not required to pay me. Okay, so carriers aren't going to go where they're not going to get, the providers aren't going to go where they're not getting paid. So I've spent a lot of time with Erica. I know, again, Medicaid pays here in Georgia. That's the good news for our state. If you're here from another state, you'll have to look at that state. Commercial, in a parity law state, you're going to get paid as if you're there. And in general, their reimbursement is the same. And so we don't get a special rate for telemedicine as opposed to non-telemedicine visit on that particular CPT code. So improving, when we first started, there were about 8 states that had parity law and very few that had reimbursement. Now there's over 400 pieces of legislation for some kind of telemedicine reimbursement, but it is confusing, so.
So it sounds like we're making good progress, and Georgia apparently is very fortunate to. That's good. That's good news. Well, there are obviously a lot of barriers to getting. Besides the financial, there's partnership relationships and the technical side. I'm going to ask Steve, what are some strategies that you would suggest for overcoming the barriers of financial and operational and partnership relationships, that type of thing, because you have to deal with that all the time.
Julia hit up on something really well, and that was her talk about the barriers, about the difficulty of bringing the multi-parties together. If you think about a successful telemedicine program, you've got the larger hospital that receives the transfers. Let's talk about high acuity, because that's the most difficult. But you have a large hospital receives the transfers, smaller hospital that receives the incoming patient. They have to work with the EMS, and now they're not getting bypassed anymore. They may have doctors that can staff during certain hours, but not 7 by 24. So now I have an outsourced coverage model I've got to deal with, and I've got to get all the financial arrangements in place to make all that happen. And then on top of that, I have a technology to deal with. So, and then I may have competing different EMRs. I have one EMR at my small hospital, a different EMR at my big hospital. That patient is now owned by two hospitals at that point in care on a remote counter. So what you said very elegantly was it's a complicated transaction to put together. Once you get it all put together, it works very well. So to answer your question, Glenn, directly, it's a leadership challenge, right? So someone has to have the guts, the stamina, to kind of drive through it and bring all these parties together to envision a successful program. And that's what Dr. Canto and the group out of Augusta University. By the time I get used to GRU, you can change the name on me. But you guys have done a fabulous job of leadership at Augusta University. So you guys really drive a lot of good behavior. So, but I think that's the biggest challenge. It's a leadership issue. It's not a technology issue. It could be a payment issue. I mean, look, all these things are excuses for not going forward. But at the end of the day, it's a leadership issue.
I would definitely agree. I think we've heard about reimbursement, which is a challenge. We've heard about law, which is a challenge. But really, we found in our business, it's adoption. And driving behind adoption is the leadership issue. I can tell you, I'm in rural Georgia all the time. I feel like technology has gotten so cheap, any hospital in this room can afford to put it in. I feel like it is not difficult. We just brought up a hospital in Middle Georgia in less than 8 weeks with a program. In their first, 4 weeks, they've seen maybe 30 to 50 patients and had a very positive impact. Took them 9 months to get the leadership to drive the change through a very small hospital. Turnover in a rural hospital, I think, is very problematic. We've started down the trail with many hospitals, and halfway through the project, we have a changeover in the CEO, we have a changeover in project management, we're back to square one. Dealing in a 3,000 delivery hospital in Alabama, same thing. 18 months down the trail, new CEO decides, not my program, not going to do it. I agree with Steve. You need a driver to get telemedicine active in your facility.
Well, that's not good. Let me ask you guys this. How receptive do you believe most clinicians and executives are to, let's use a broader definition of technology beyond, the hub and spoke, but so how, are they confused? Are they intimidated? Are they excited? I mean, how would you characterize that? Who'd like to?
I actually am very encouraged because I see more healthcare systems speaking about telemedicine today than ever before. And so in that regard, I think people recognize that it's coming and they're trying to figure out, what is my starting point? What makes sense for my facility? So in terms of the conversations and actions, hopefully actions will follow. But again, like with legislation, more payment, more activity, more legislative, and I think more people talking about it. So I think we're kind of starting to move beyond talking and starting to do, where I feel like it feels like that.
Cool. So my experience is mostly from the nursing facility side of things. So we've done a fair amount of work thinking about attitudes towards adoption and use of telemedicine, but I think this broadly applies to sort of health IT applications more generally. And there is, you talk to folks, you talk to administrators, you talk to clinicians that work in these facilities, and there's a lot of enthusiasm. So we've done interviews, we've done surveys, and there's enthusiasm both for the economic potential, but also really for the sort of clinical quality of care. There seems to be real confidence in the idea that telemedicine could change things and the way that care gets delivered. But again, then there's this issue of how to do it. And so when you talk with them about the challenges and the reasons that they haven't sort of pursued it further, it's ROI, right? It's this very unclear sense of what is the return going to be for me, which I already mentioned, but also what is it going to take financially to actually get this system up and running? And I think that's as much as the business civil reimbursement piece is murky, I think this idea of the startup requirements, both financially and otherwise, is a big black box that tends to sort of lead to inertia. And the workflow changes, right? Because then there's not just, it's not a binary adopt or not adopt decision. It's adopting, but then also making sure that telemedicine card is actually getting used for something and you aren't hanging a lunch cooler on it, right? That it's getting deployed at the right times. And so I think the idea that it's this sequence of decisions is what takes sort of enthusiasm when you're sort of just ask someone, when you ask them sort of in a survey, and dilutes it somewhat.
So would it be fair to say that maybe because of other priorities and strategies, or not strategies,
Yeah.
if it's a new idea that has to kind of crowd out some other things, is that a factor, you think?
Yeah, I mean, so Shiv, you can speak to this a little bit better, but from my perspective, sort of sitting back from an armchair perspective and thinking about telemedicine in this setting, I think this idea, so there's a lot of exciting sort of, at least sort of in Western PA, a lot of frontline sort of innovation going on, but it hasn't gotten to the point that it's sort of trickled back up to be mainstream. So the idea is fascinating, but the actual execution, it just feels unmanageable.
Yes, all well said. I mean, here, let me answer that question a little differently. Tell you what I think fails. I mean, so it's kind of like another inverse way of looking at it. So the programs I've seen that fail miserably are the ones where management says, this is what we're going to do, and we're forcing everybody. So what happens there is that, you know, the ED nurses, they don't want to deal with it. One more piece of technology, one more login, they revolt on it. The doctors that may be on call, they don't like it because all of a sudden they have call and what's their call pay going to be and how are you going to work that out. I mean, so you run into all these labor issues where the people who actually have to make it work are not bought into it. So it's one of these things, like you said very well, it's like conceptually everybody likes the idea, but then to make it work is a challenge. So everybody sees these personal roadblocks or issues that they have to deal with that you have to overcome. So that's my 2 cents on that.
I would agree with Steve. At my last presentation to a Florida mid-sized hospital, we had 10 different departments and almost 30 different stakeholders at the very first meeting.
40 different opinions.
Absolutely. I think pretty much the pulse in the room at the beginning was hopeful but extreme skepticism. Walking out after they can see it, it's demonstrated, it's kind of a see it to believe the impact it can have in your hospital. And when they really get a lot of clear information on it's possible, it's not as complicated as you think, the technology has been there for a very long time and getting cheaper. I actually had people walk me out saying, I didn't even want to come, I'm happy to see you again. So I think it's just getting the right information to the right people. It's very, very doable, but I agree with Steve, you have to get the stakeholders in rather than have it be forced on people.
That's good. In the spirit of positive and upbeat and looking forward, I'm going to ask Julia this question. Let's project 5 years into the future. To what extent, how big will the impact of telehealth, telemedicine, disruptive health, you know, that whole continuum, on a scale of 1 to 10, how much difference will this make for healthcare in general, and then secondarily, specifically in rural health? Do you think it'll be the same or more or less?
Okay, so I might not be the right person for positive and upbeat, but so I think so because I think it depends, right? I think we're sort of this. If you even just want to focus on telehealth, which I think of the emerging technologies has moved relatively far, right? The market is still so young, and there's a lot of call for policy, but there's been relatively little action, at least on a very large scale, right? So you have Medicaid programs that have pushed the ball forward, but in my opinion, actually, I think a lot of people, a lot of providers, a lot of facilities are waiting to see what Medicare is going to do, right? I think that would change. That I have no. It would be very exciting. I think it really depends on what kind of other policies come into play in the meantime, right? And whether they sort of go the more fee-for-service route, which tends to be sort of a lot of the calls around telemedicine and telehealth have this fee-for-service bent, or if we sort of attach onto this broader alternative payment model, ACO train that is really sort of has left the station and is moving. Does anyone want to be upbeat about this?
I'll be very upbeat. So my first year in telemedicine, I went to a national presentation by a university. I was very excited just to see what they were doing. They concluded by saying we did 95 telehealth visits this year. They were a major university. Major university has about millions in subsidy money. These days, it's very easy to really rack up the visits. So I see things going a little bit faster in terms of what we used to do maybe when we started 10, 15, 20 visits in a month. We're doing hundreds and approaching thousands in a month in a few short years. The other thing I wanted to bring up is consumers are driving the train faster than us in rural healthcare. So when you have the payers saying, I'm going to put a rider on your plan when urgent care closes at 8 o'clock, you all can get on your laptop. You may not get your entire treatment funded, but you can get enough medicine or treatment, whatever, for Monday morning. We now have consumers driving the train toward telehealth faster than us in healthcare facilities. Next week, we'll go to the American Telemedicine Association meeting. There'll be about 8,000 people there. Probably 40% will be international. Globally, they are driving the healthcare train faster than we are in the United States because they're ready for adoption and they need it because of the underserved areas. So I'm definitely way more positive.
10 years out, was it 5 years out? Okay. Well, 5 years out, I think it'll be fairly prevalent. I mean, telemedicine will be prevalent in many places, particularly in rural. It'll be an exception not to have it, particularly for high acuity cases where you have specialists. Here's an example. We just did a survey, and it'll be on our website sometime next week or week after. But we had 16 criteria for how you ranked your telemedicine program. And there's 400 some odd respondents. And the number one success criteria was rural access to specialists. It was 60 some odd percent said that was their number one success criteria. So that was, I thought, pretty good indicator of how they measure the success. The other thing that's happening, the other thing in terms of reimbursement in Medicare, I don't know if you guys watched Tom Price's confirmation hearings. So I did only because he's my senator, my congressman, and I've met him a few times. So I know him not well, but I've met him a few times. And in that confirmation hearing toward the end, he mentions the Augusta University program. He mentions it by name. So he would call his legislative assistant Emily would call us every year and ask us what we would like to see on the legislative calendar around reimbursement for telemedicine. So I know he's an advocate. So let's assume he's got some power there, right? So he's going to hopefully make some change in a positive way. So I think that's going to help. And the other thing that's really driving a lot is the technology. He was bought a recent iPad or a new iPhone. I mean, the camera is unbelievable, right? I mean, you wouldn't gotten that 10 years ago. And then the things we expect, like even on the consumer side of the world, we expect that stuff to translate to the business side or the clinical side in healthcare. So we have this high expectation of great images, fast bandwidth, really nice applications that work seamlessly as I treat the patient. So all the technology vendors are rushing to try to get that. And then the other thing to kind of think about, there's been over $1 billion of private money put into telemedicine companies. And over $500 million of that has been in the consumer side, people like Teladocs, MD Live, Doctor on Demand, et cetera. So they are selling their services, and they provide doctors and a secured, HIPAA-secured AV solution to the health plans on a per member per month basis. So you get a health plan, you get an ability to pay $40 and get someone to tell you what's going on. So you're right, the consumers are driving this, which will then filter into the hospital side. So I think from the rural standpoint, you're going to get on the train sooner or later. I mean, healthcare is not the first adopter of anything, so it may take a while to get there. But in 5 years, I think you'll see a totally different complexion in 5 years out than you see today. So
I'm going to open it up in a moment for audience questions, but I have one last question for the panel. Let's forget the hub and spoke physician, the more restricted definition of telemedicine. Last question to you guys. Looking at apps and peripherals that plug into your iPhone and, distributed stuff that's not tied into the IT system of the hospital, all the emerging disruptive stuff. What's your opinion about that? How important will that be? Again, not the traditional, what we think of telemedicine. So let's just get a couple of thoughts on that.
So telemedicine for home use is already here. I mean, one of the big technology changes that has happened is we used to go, even for highly specialized care, to like a specially outfitted cart model to just apps on your laptop. We now have glucometers through a smartphone at home that can feed into a data bank or an EMR. We have blood pressure devices that come in. We have scales that come in, so we can monitor heart disease at home. Coding and reimbursement for home monitoring is a big bugaboo, big issue right now in telemedicine. But again, with consumers driving it and the cost of chronic disease, the fact that, Steve brought up, just sit at home with your laptop, just connect on your iPhone. We sometimes do training classes now on an iPhone because we're having to reach the patient where the patient is, and really hardly anybody sits in front of a desk anymore. They have their device with them in their pocket. And so a lot of healthcare apps, wearables, are a whole nother thing. You know, we're able to have little discs on our chest that have blood glucose levels with no wires. So I think we will begin to see integration of, it's driving down the cost too. You know, our first telemedicine cart we bought, I think, was around 35,000. Our latest implementation was less than 10 in a hospital. So 2/3 of the cost driven out in 18 months. It's just really getting cheaper and cheaper and better.
Yeah, so I have two thoughts on this. First, so one positive and the other slightly less so. But the first is I think this will move quite quickly, and one is that this data is just being generated automatically, right? So in terms of thinking about analyzing impact from both a clinical and financial perspective, it's going to move so quickly that we'll be able to support that, right? So stuff that works will get out there, and presumably that diffusion will pick up a little bit. Secondly, slightly less upbeat, but what works here, the silver lining of sort of a system where we sort of know at a broad level there's a lot of inefficiency is that there's room to make a big impact, right? So this clinical and financial outcome thing can move together fast. So I think between those two things, there really will be nice momentum for the whole sort of sector in general.
I guess only to add to that would be the way that I think a lot about this is that because the technology is so pervasive now, and the kits that people can use are so relatively easy to use, I think it'll be a physician-driven kind of innovation. In other words, I think the physicians will see, like, let's take, the opiate thing we talked about today. I mean, some really bright physicians are going to realize they can take wearables, they can take some devices, cobble them together in a way that will help either deal with that addiction or help catch it early. So I think the physicians, because I think look a lot of medical technology is basically a physician-driven idea on a precursor of technology. And I think you'll start seeing the physicians start driving more innovation around this base technology that's come out with wearables or biometrics, or it could be, I don't know if you guys have used the genetic testing of finding family history, 23andMe, I mean, it could be things like that people do, and they download it to a data set, put a wearable on, and now all of a sudden they can monitor certain behavior, right? So there'll be all kinds of interesting ideas, but I do think it'll be physician-driven to a large degree.
Okay, well, what questions do you have in the audience? Yeah.
So Lisa and I were talking about this on the break from the rural stabilization grants. Upson County here in Georgia was one of the beneficiaries for this past year. One of the many projects that they chose was deployment of our maternal fetal medicine program. So they are the only hospital delivering for about a 75 to 80 mile area. They're the only labor and delivery hospital. From the time that we signed our agreement to provide services through telemedicine, within 9 weeks, we had trained their technologists. It cost them probably less than $15,000 start to finish to set up their telemedicine program. They are right now at about 4 weeks into it. They've impacted it. I think they've seen close to 35 patients in 4 weeks. And that's with us throttling their schedule because they're learners to telemedicine. They're operating about half of what they will be when they're fully there. So I think a lot of times people think it's very complicated. I can't get through it. Now, I can't tell you, we were talking earlier, it took them 5 to 6 months to get to the point that they were pulling the trigger. But it's not that complicated. It's not that expensive. These were people that were driving, high-risk OB moms driving almost an hour and a half to the next closest care provider. And that's here in our state. Not that complicated, not that difficult. Got the help that they needed to do their initial CapEx, and then they're up and running and affecting. They will probably, on their ROI, they will probably meet their ROI for their cost probably in less than 60 days. They will probably impact 300 to 500 pregnancies in their community in their first year.
I mean, that's a fundamental premise of, I think, of telehealth or telemedicine is I can extend my reach. I can extend the, you know. Yeah, but besides the one-to-one interaction, kind of like the force multiplier. Yeah, the answer is yes, in the sense, particularly with academic universities, because you can have the residents and the students participate in that treatment. So you can basically, it's a learning opportunity, if you will, teaching opportunity, but real time with a real patient. So the answer is yes. No, I don't think is people. Look, I'm not aware of anybody thinking about telemedicine and Project Echo, if you will, all bundled together. There's probably an opportunity in there, but I'm not aware of anybody working on it. So, yeah. If I can add, I mean, just for, I don't know how many CEOs of small hospitals we have here, but if I'm the CEO of a rural hospital, here's what I'm thinking about telemedicine. Can I get more patients to stay in my bed? Is my ambulance going to bypass me? Right? Right there is probably a time saver. Second, do I get a reputational impact on the community where now all of a sudden we can treat, pick it, stroke, heart disease, high risk OBGYN. I mean, pick the service line. I mean, so there's a series of things to go through. And once you hit 2 or 3, it's got to be a positive payback because the technology is so cheap now. So that's how, not that I've ever been a rural hospital CEO, that's how I would think about it. So, yeah.
So we are out of time. This is very exciting. I wish we could spend another half hour on this, but we need to thank our panel.